Now we're going to do something interesting. We're going to invite Mr. Health Minister to join us up here and have a little discussion around what we just heard. So, welcome to you.
Thank you. Great listening to you.
Can we talk about toilets and bathrooms?
How much time have you got?
I thought I would take the word in the first, because I probably won't get it back. Mr. Health Minister, we just heard about a different system, and of course I would like you to start to comment on what you have heard, but I couldn't resist taking the chance of asking you, are we throwing birds?
Well, that part of the analysis, I think, is very accurate and very much corresponds to how we have to see modern medicine, modern society. And as I try to emphasize in my talk, I believe that much along the same lines here, that there's a much more complex approach to what is health, what is the way you manage your own health, your own responsibility. As I say in Norwegian, du ansvarlig for din helse, alle ansvarlig for alles helse. We all have a shared responsibility, and I think this was a way they do it in this system. Then I think for the rest of the talk there is a lot of deep structural differences, of course. And we can maybe come back to some of them, and I would hope that our discussion could not get absorbed by those structural differences which are real because our systems are so different. Right. But in terms of philosophy and approach, I think there are many things that are very similar.
I agree. So I thought we maybe could separate this conversation in two subjects. Firstly, what's to learn when we look at the system, and I would like to concentrate on what should we learn as municipalities. How can we start this journey? We have a cooperation reform that's trying to change the direction. So that's one part, and of course it's necessary also to focus on how can individuals be more responsible for their own health, as Josh finished. Is that a...
Yeah, I'd like to respond to that. One of the things that drives me crazy, because I've worked in public health, pure public health, and in medical things, and in mental health things, and in community activism and community development. And it drives me crazy that those are all separate organizations with separate funding, separate power structures, and separate ways of trying to achieve the end. And from a community perspective, we have this thing called healthcare, which is really medical care, and it's really only good for that 1/3 part. So I say in a lot of my speeches, either modern medicine should give back 2/3 of the money and only do what it's good at, which is that 1/3 part, or it should really figure out how to responsibly do the wider array of things that requires a different skill set and a different focus than what modern medicine has. So in our system, we've tried to do a huge amount of public health, so things around water and food and household safety and helmets and all of those things built into the personal relationship, because it still is motivating people to make healthy decisions in their personal lives that have public health consequences. So we've tried to use a single platform to get at the whole array, but that's certainly not the only structure that can work. But what can't work are 10 different pillars who don't communicate and talk with each other and connect and coordinate with each other. So either medicine needs to shrink and only have its proper role, or it needs to figure out how to play better and more effectively involve across the sectors.
Conceptually, I would agree with that, but I don't think medicine will shrink. To the contrary, it will expand, and it will be our democratic challenge how we will control that expansion. Because if we look at the last century, we find that Norwegians live 30 years longer now than 100 years ago. And 25 of those years are related to public health, folkehelse, and not to medical improvements necessarily. Right. But in the last part of last century and into our days, that is starting to change, because there is a medical revolution going on with genomics, biomedics, and so on, which is extremely expensive and to some extent promising. How much good it will do, we don't know. So how we can control that expansion, I think, is the challenge. I often find in our public debates that people argue as if there were two budget posts, one for hospitals and one for public health and prevention. So why don't you take more money from hospitals and give them to prevention, and it all will work out? Now, conceptually, that is right. In practice, it doesn't work that way. And I think one challenge we have, which is real, and we just have to live with it, is that our system is organized in two big tranches. I, as a minister representing the state, own the hospital, and the mayor over here is in charge of primary health care in the kommune, at the municipal level. We are trying to bridge that through a major reform, making these systems talk together. That is our kind of main approach. And then I have great faith in giving the municipality a very broad public health care responsibility. I must say that in the Norwegian culture, I strongly resist the notion of seeing the individual as a customer when it comes to health and care. I think the citizen is an empowered citizen with democratic rights and obligations, but not the customer. But that, I think, is due to the way systems are organized, which is different. I want to be a customer when I go and buy a bicycle, when I do other things out there in the market. When I come to the healthcare system, I want to have responsibilities and rights, but I don't want to be a customer. I want to be well received and well treated.
But if we change customer-owned with user-owned?
Well, that is part of being a citizen, in my view. You know, you have a responsibility. We own this together. You know, we have a tax-based health system. So in different way, we chip in through that insurance. But this new pattern of lifestyle diseases, we have to make it clear, as you very well put out, that I have a very strong responsibility for my own health. And the choices I make have a direct implication. And I think we need to have early intervention to guide me and give me advice on how I make these choices right. But we know that Norway, being a quite equal country compared to other countries, we have our greatest inequities, differences, social differences in health. There's no other field where we can read differences in my country more clearly than exactly in health.
Well, I think Josh tried to make the point, and I would just re-emphasize it here, that in that customer-owner term, our biggest emphasis is on the owner part. And in our system, the system is owned at a macro level by Alaska Native people, but the main point of the term is the individual ownership. So a huge agreement with what you're saying, that the issue of, it's the whole diagram thing I tried to throw up there, where the individual is in control. It's not whether we want to give them control, they already have control, but making that transparent, making that intentional, and having the system respond to that with intentionality is what's often missing in healthcare and medical systems. So huge agreement with what you're saying. Also would have huge agreement with what you said before about your role and the mayor's role and how that piece works. I agree, medicine's not giving back the money. So if they're not giving back the money, the real question is, how do we make where the money is actually achieve the ends that society expects for the money that society is putting in there? And that's where I think just tolerating, you said in your earlier thing that the other minister said that health ministry was too important to leave to the health minister, and I would say health care is too important to leave to the doctors. And this increased voice of municipalities, government officials, policymakers, and the patient and the family, the doctor should be the servant and the responder, not the controller and the driver. And that's huge. That is massive in its implications.
I'm happy that the doctor is saying this, because then I can come in afterwards.
We'll leave that part to him.
Because
I have scars on my back; they're only partially healed.
But let me be a bit blunt on this. What are we up against? We're also up against a very strong professional transition.
Absolutely.
Of the doctor, and I have, we all have doctors close to us, and we don't want to get them upset because, one day we will need them. But we moved from a system where they were the almighty, and we were. I launched our national cancer strategy last week, and I learned from the Cancer Association, Kreftforeningen, a woman who said that there was an operation 30 years ago, and the patient didn't know that she was operated for cancer. Mm-hmm. The information was not shared. So I think a major change now is in our hospital care and in the whole care system is to make the patient the key person. It may sound obvious. I believe it's a human right, but it is also through research well documented that it gives better treatment, better care. But I think that for the whole medical profession to acknowledge that they are now entering into a much more multi-sectoral team, where their contribution is crucial, but only one of many. And what I would like to see, I mean, turning to the municipalities, that you have to take that agenda and capture it to some extent. Take a look at the front pages of today's newspapers. This is a random day. And count the number of top stories, which is about one, and may I say, not major, but one mistake in a hospital. And they are real. You know, there are 6 million meetings between Norwegians and the hospital system per year. And if 1% of those meetings are not 100%, that means 60,000. So there's enough to take from, you know, to tell stories. But the real stories we need to lift out, to shift our focus as a society, is the one that I will do later today here in Arendal, which is about how you promote physical activity, how you create the conditions for kids using their bikes to school, because that's where the prevention lies. And if we do that right, there will be fewer stories of people going to hospitals. And in Norway, I think we have that equation very wrong. We still are massively focused on the specialized hospital sector.
Right.
It is if it is a race towards that sector, and when you cross the line into the hospital sector, you become visible, you get rights, you get attention,
Right.
and if it doesn't go well, you get the front page. Here's your package.
No, I think I think that's exactly right. And I think you hit on a couple of really key points that are important to emphasize a little bit more, which is one of the difficulties in society. Well, first of all, I massively agree that the answers are not going to be found in hospitals. The answers are going to be found in communities and what I would call also this longitudinal relationship piece, whether or not it's done with doctors. And I personally don't believe it all has to be done with doctors. In fact, that's what gets me in trouble a lot. But the other piece that I think is really difficult is that hospitals are large, organized businesses. And so within that structure, you have the capability to do political lobbying, to set policy, to drive quality assurance, and to drive quality improvement and design. And in the community primary care and community-based things, it's fragmented. You have all these little tiny small organizations who don't have a place where they convene, pool resources, and create a superstructure that can create methodology, improvement, transformation, change, and lever systems like you can with the organizational structure of a hospital. And that's part of what it's partly the medical model, it's partly this this manufacturing protocol-driven stuff I talk so much about, but it's also just inherent in the structural strength of a big entity like a hospital and the structural weaknesses of many little primary care offices, mental health offices, and community-based activities. I think that's true here as well as in the United States. And that's a difficult problem, which means people in power, mayors, ministers of health, other people, have to own some of that agenda out here and not just the changing of the big hospital system. Am I making sense?
But that I you know, as you say, I massively agree. I like that is a big agreement, you know, when you massively agree. And I, you know, really, to be again a bit frank with doctors, because I respect them so much, I believe that when you see doctors' voices out there in the public debate in Norway, it is 85% to 90% about, you know, need for more resources in the hospital. 90%. Yeah. And I think that when the most cherished group in the Norwegian society is the primary healthcare physician, fastlegen. And I would really like to hear much more of those voices. What do they see? Not tell the patient stories, but what is the picture they see of public health? Where are the needs? Why are we getting an increase in mental health problems? Because we run after the symptoms and we leave the causes. So, you know, I think that the skilled media people in the medical profession, they are about, you know, we need this extra machine in the hospital, we need more employed doctors in the clinic, we need, you know, interest-driven messages from the hospital. But with all the experiences of that primary healthcare sector, I'm astonished that there are not more voices out there.
But do they have the same kind of corporate structure and platform and base from which
because
to...
they are largely individual businesses,
Exactly.
They run their own offices.
Exactly. So that's a huge structural problem.
It's a massive problem.
Massive problem.
It is.
But I'd like to put on a table, if it's here, something that is about not only the doctors but all health professionals, because I think in our education and our culture and history, it's all been about reparation. It's all been about focusing on how to compensate for diseases, for weaknesses. And the health promoting activity that your work has been very much about is a contradiction to our education in a way. Because we need to think differently, I think, as health professions to really go into the health promoting activities.
Yeah, but that has to be done through structural reform. And Samhandlingsreformen is one such reform, which is giving, through legislation, primary responsibility to the municipality. We have to divert money to the municipality to back up those tasks. And we are creating new, also economic incentives of co-financing for hospital. That is a cultural shift, clearly. But you know, when I said that health is too important to be left to health ministers, when we worked on the white paper to Parliament on public health, what I found interesting around that government table with my colleagues was that in a way, I started to understand that I was a minority holder of that report. Because more important than what I do in the health sector is what the transportation minister will do, what the industry minister will do, what those other ministers who kind of are in charge of sectors where we live our lives. I mean, take one example. Traffic injury in Norway in 2012 is coming down to 1952 level. There were fewer cars in Norway in 1952, and injuries are at the same level. That is a massive public health improvement. Another sector which we now acknowledge as a very, very serious health problem is domestic violence. Vold i nære relasjoner. That's not the health minister's responsibility. It is for the Minister of Justice, children, family. But, you know, all these are ministers with labels. It is back to the community. It is back to the social capital of communities. How do we mobilize that? So I think I'm optimistic because I think the big transition in our health sector is moving towards the community. Seeing the non-government sector, frivilligheten, acknowledging the responsibility of the municipal sector. We will have a challenge because our municipalities are different in size, and again, there are different ownerships, but we can manage that through, you know, these structural reforms.
And in the municipality, it's equally important that we bring the forces together.
But that is happening, you know.
Yeah.
I think now it is no longer one single person dealing with health, but the whole entire leadership in the municipality has to engage, and that is happening.
But part of the conversation is not just getting people together, but also opening the way to have conversations about topics that haven't been owned anywhere before. And you hit on a really big one, which is violence in families and family violence. And in our parallel session this afternoon, we'll talk about that. And as our system has been more and more completely given over control-wise to the community, the agenda for the priorities, where they want to see the money spent and the time and energy spent, has been shifting. And so we now talk about a 3-year gestational period for pregnancy, from 3 months before conception to 2 years of age, as a single gestation, which is a little shocking to women who think it's a 9-month gestation and don't want to see it extended. That's a joke. So we talk about that. We talk about violence in families and what do we do about that institutionally and structurally. And that's not the boundary between kind of medical and healthcare and community and municipality starts to get really, really blurred, and it just becomes a community and customer owner-driven agenda about issues that affect their health and well-being, and they start to tell us where they want the money, where they want the time, and where they want the energy, and it ends up being in those areas. And by doing it in collaboration with the healthcare system, you draw on that structure capability, that improvement and initiative and workforce driving and staffing capability, rather than trying to create it separately over here somewhere with money that doesn't exist in a resource-scarce environment. Does that make some sense?
Absolutely.
So those boundaries are important, and I'd like to get one more thing on the table before we're out of time. I know we're out of time, is the workforce issues, and we've hit it a couple times, and Mott directly hit it, which is we're starting to explore a lot. How do you have technicians do things that doctors previously did? So endoscopies, cataract removals, dental health aides that are drilling and filling teeth with 2 years of training right out of high school. There's a whole long list of things that you can have technicians be doing safely if they're concentrating on doing that one piece, and you don't need 4 years of medical school to replace a knee, for example.
And I'm going to lead that parallel, so now it's my time to say I massively agree. Gentlemen, thank you so much for this insightful debate.